Yes, yes.
Okay, sir. Should I start, sir?
Yeah. Yeah. Please go ahead.
Okay, sir.
Pen and paper. Go ahead.
Yes.
Is it Dr.
Yes, sir.
Rishika?
Yes, sir. Sir, my slides are visible.
Yeah, it's okay. Dr. Rishika in a very broken manner. Is it a problem with my computer? Yeah, your slides are visible, but is it a problem with my internet connection or Amitav, you are able to hear?
Yeah. I can hear and see the slides as well.
Yeah, slides are seen now. Okay, go ahead, please.
Okay, sir. I'm presenting the case of a 17 years old female who is resident of Hooghly, West Bengal, studying in 10th standard, belonging to lower middle class by modified Kupuswamy scale. She presented to NSH Havda on 28th of September 2022. She presented to us with the complaints of breathlessness since 2 years. As the history dates back to the infancy, so I would like to start my history with the childhood period. Child was born as a full-time vaginal delivery with a birth weight of 2 kg in the hospital, and she cried immediately after birth. There was no respiratory distress. However, she was kept in the NICU for low birth weight and was diagnosed to have an anorectal malformation for which colostomy was done. She was evaluated for other congenital malformations and was told to have a heart disease which would require surgery in near future. There was no respiratory distress, cyanosis, and feeding difficulty, and was discharged home from the hospital after 1 week. Slides are not moving. She remained apparently all right till 1.5 months of age, when the mother observed that she used to have hurried breathing and excessive sweating with feeding. She also had difficulty in feeding in the form of suck-rest-suck cycle with a total increased time of feeding. She also had poor growth as compared to people. Yes, sir.
Amit, I want to log in from my phone.
Yes, Shiva. Yeah, Dr. Shiva. Tell me, please.
I am not able to hear her very. I have it's saying that the host will let you in soon. So can you?
I've already allowed.
Doctor.
Yes, sir.
We can hear you intermittently.
Sir, am I audible correctly?
Yes.
Rishika,
yes.
Please go with your previous slide and can.
This one, sir.
You are telling that breathlessness. The previous slide, please. Yeah. So from here, please start. Sorry, I didn't hear.
Okay, sir. Should I start, sir?
Because
So this is a 17 years old child who is presented to us with breathlessness for 2 years. Hello. Should I continue, sir?
Dr. Shiva is rejoining. Just wait. Huh?
Sir, is my audio okay?
Yeah, now it is okay. Please go ahead.
Okay, sir. Okay. Sir, I am presenting a case of a 17 years old female who is resident of Hooghly, West Bengal, studies in 10th standard, belonging to a lower middle class socioeconomic status, who was presented to NSH Havda at 20th of September 2022. She presented to us with complaints of breathlessness since 2 years. As the history dates back to the infancy, so I would like to start my history from the birth. She was born as a full-time vaginal delivery with a birth weight of 2 kg in hospital and cried immediately after birth with no respiratory distress. However, she had an NICU admission for low birth weight and was diagnosed to have an anorectal malformation for which colostomy was done. She was evaluated for other congenital diseases and was told to have a heart disease which would require a surgery in near future. There was no respiratory distress, cyanosis and feeding difficulty, and was discharged from the hospital after 1 week. She remained apparently all right till 1.5 months of age when the mother observed that she used to have hurried breathing and excessive sweating with feeding. She also had difficulty in feeding in the form of suck-rest cycle with a total increased time of feeding. She also has poor growth as compared to peers of same age group. However, there were no retractions and she remained comfortable at rest, all suggestive of modified Ross class 3. There was also one episode of hospital admission for pneumonia at 3 months of age for 5 days, and IV antibiotics and oxygen therapy was given. No ventilatory support was there, and child was with the mother. At discharge, she was given diuretics oral. There was poor weight gain, but no further hospital admissions. An open heart surgery through median sternotomy was done at 6 months of age, after which she was in the hospital for 7 days. There was no prolonged ventilation and she was discharged on oral diuretic drops and advised for regular follow-up. She underwent corrective surgery for the anorectal malformation at 9 months of age. She remained apparently asymptomatic till 2.5 years. When she again started having difficulty in breathing while even playing for a short period of time, she had poor weight gain but remained asymptomatic at rest. There was another episode of hospital admission at pneumonia at 3 years of age, for which she was admitted for 4 days and IV antibiotics were given. Cardiac opinion was sought and it was told that she shall require another open heart surgery. There was no history of cyanosis, facial puffiness, excessive crying, vomiting, reduced urination, and abnormal body movements. She underwent another open heart surgery to midline at 3.5 years of age with a very short post-ventilatory period and was discharged 5 days after surgery without any medication. Apparently, she remained all right all these 13 years and was performing her daily activities
Recording in progress.
like pursuing regular dance classes till 2 years ago when she started to have breathlessness initially on exertion while taking 3 flights of stair, walking nearly 500 minutes and pursuing her regular dance classes, which gradually progressed when she had to decrease her duration of dance class. She developed breathlessness while climbing even one flight of stairs, that is from NYHC 2 to NYHC 3 currently. However, she is comfortable at rest, is going to school and does not take part in regular play. There is no history suggestive of orthopnea and PND, no cough, wheeze, expectoration, fever or rashes, swelling of limbs or abdomen, giddiness, loss of consciousness, chest pain, palpitations, sore throat, joint pain and fever, hemoptysis, swallowing difficulty and change in voice, weakness of limbs and any abnormal body movements. To summarize my history, I have a 17-year-old female with a known congenital heart disease at birth with 2 hospital admissions for pneumonia, failure to thrive with anorectal malformation, with 2 midline open heart surgeries at 6 months and 3.5 years of age, who remained asymptomatic for 13 years and now presented with dyspnea on exertion, which is suggestive of NYHA class 3. My first differential diagnosis would be an AV septal defect which was taken for a full repair at 6 months of age and underwent and had a AV valve regurgitation, which was taken for surgery at 3.5 years of age. A large VST with a bicuspid valve, the PA band, which was followed by total repair, a VST with residual VSD and a subaortic membrane, a congenital AV valve regurgitation, the corrected acyanotic heart disease. My last will be a very sleek differential diagnosis, that is a corrected acyanotic heart disease with a current rheumatic heart disease. However, this is very low down in my differentials.
Okay.
Should I continue, sir?
No, let us see. You told that the heart disease was diagnosed during the early diagnosis of anorectal malformation and almost in the neonatal period. Correct? Hello?
Yes, sir.
And can you hear me?
Yes, sir.
And subsequently, you mentioned that at 6 months, the child had the first cardiac surgery.
Yes. Sir. Hello.
Yeah. See, the features were the patient had features suggestive of congestive heart failure, possibly a left-right shunt because you had 2 episodes of pneumonia. There was significant growth failure. I agree. Now,
Yes.
about the 2 surgeries that were done at 6 months and 3.5 years of age, both, how can we come to a conclusion that it is open heart surgery? It is, you meant to say that it is through midline sternotomy and some surgery.
Yes,
okay. So since some of the surgeries like pulmonary artery band and all may not be called as open heart surgery, probably it is better to retain the terminology as midline sternotomy, right?
Yes, sir.
Okay, fine. Your first diagnosis is AV septal defect with AV valve repair, AV valve regurgitation. You could get any information about what was the treatment history at various points of time? Like
Yes, sir. I've mentioned that she was always given an oral antidiuretic, oral furoped, that is furosemide drops. Apart from it, nothing was given to the child.
So this oral furosemide was given after the 3.5 year surgery continuously till now, 17 years, is it?
Even after the 6 month surgery, she was advised on furosemide drops after the first episode of pneumonia, that is at 2.5 months of age, and that was only continued after the 6 months first surgery. She has not been on any other medication apart from furosemide drops till now.
Okay. So continuously needing some form of diuretics.
Yes.
Could you gather some more information about whether the parents are noticing a significant increase in the precordial activity, or parents are noticing significant pulsations over the precordium, which might indicate that there is an ongoing volume overload of the cardiac chambers?
So between the 6 months and 3.5 years of age, there was increased precordial activity. But after the second surgery, there has not been any increase in precordial activity observed by the parents.
Okay. In that case, what do you think? Like, assume that you are having the first diagnosis of AV septal defect where primary repair was done initially, and then you told that the 3.5 years second surgery was an ultra short surgery, like very rapid recovery, correct?
Yes, sir. After 5 days, she was discharged home.
So on that surgery, you feel if suppose that is the first diagnosis, the second surgery was a surgery for just an AV valve repair. Left
yes, sir.
valve.
Maybe yes, sir. Because even after a repair of an AV septal defect, there are chances that 25% undergo a re-operation for a cleft, which is or an LV obstruction. So, but more common would be an AV valve repair surgery. So, that would
like,
be my first.
Okay. Is that one of the surgeries where you get a very, very fast recovery? Yeah, an AV valve repair in the setting of an AV canal defect operated. Is the recovery so fast as you anticipate? What is the normal?
No, sir, because along with the repair itself, which is cleft itself, also there is annular dilatation along with the dysfunction, which might need prolonged ventilation for supporting the LV.
So I mean, among the various cardiac surgeries, repair of leaking left AV valve in the setting of AV canal is one of the very complex surgeries.
Yes, sir. AX3 almost.
Yeah. So this period of stay is likely to be longer, right?
Yes, sir.
But anyhow, okay, that is one of the possibilities. Second one is large VSD with bicuspid aortic valve. Why should there be a PA banding?
So maybe because like the first surgery was done when the child was 6 months of age. So maybe the VSD was large enough and the patient was very, she had a very failure to thrive. So it might be possible that the surgeon would not have wanted to go on a pump. He would have done a PA band first and then later repair the VSD, or there might have been multiple Swiss cheese VSDs, which he would go for a PA band first and then at later stage would go for an apical exclusion or a complete repair. That's what I heard.
Okay. So what are the indications where a VSD in a patient may go for pulmonary artery band rather than a corrective surgery? One you told, the first one, I agree that if it is a Swiss cheese type of VSD, then what else? What are the other reasons why VSD may go for?
There are very large VSD with a patient who is very septic or a very sick child who cannot undergo, who cannot do us. So that would go for a PA band or a inlet type VSD with straddling, which is causing a large amount of volume overload. And the patient is very sick or has a very low weight. So patient, he would like to go for the PA band to control the overflow situation. So maybe straddling or maybe large VSD with septic child.
Okay. So VSD that is complex, which cannot be repaired in a very, very young child, and where the surgeon may be confident of taking up at a relatively older age. So what are all the various things? Already somebody has popped off this. Suppose there is a minimal amount of straddling override of an inlet ventricular septal defect. It may be difficult to handle that VSD during the early infancy. However, it may be relatively be easier a little later. So I think many of the morphological differences that may not allow an immediate closure. However, over a period of time, when the baby is larger, in fact, there are in the chat box, people popped up as hypoplastic, borderline hypoplasia of one of the ventricle, borderline hypoplasia of one of the AV valves, an inlet VSD with little bit of straddling, an inlet VSD with little bit of overriding. So these are all some of the conditions where a VSD will go for a primary repair. In the past, we used to think that a patient who is very small, like for example, say 2 kilo or 2.5 kilo, it is easier to handle them with a PA band rather than a primary closure. However, the morbidity of a PA band is quite profound. So always a corrective procedure becomes a much more predictable postoperative course rather than a PA band. Because what are the difficulties of PA banding in a patient who is very septic, having significant pneumonia or significant other lung issues? What are the difficulties in doing the PA band? Normally, when you do a PA band, you do it with an intention to control the pulmonary blood flow. So when you are trying to band a very small baby who is already having a very bad pneumonia or a very bad lung condition, the PA pressures
are high, are very high.
And so the patient will desaturate much earlier, even when you begin to start the banding, despite the fact that the PA pressure is still very high. So it becomes very difficult to manage them. So contrary to what we used to say many years before that, it is easy to handle a PA banding, that means a closed heart procedure in a very sick patient. Today we have recognized that it is actually more easier to do a complete correction in a very complex, sick, septic, pneumonic young infant. But anatomical problems are really difficult to manage. Anatomical problems are, as was mentioned, a straddling, a partially straddling. Of course, a grade 3 straddling and all will straight away go for an univentricular.
Single.
But if there is maybe a grade 2 straddling, where or a borderline hypoplasia of one of the ventricle, or these are conditions where the surgeon would like to take some more time to do that, and hence in these patients pulmonary artery banding may be done as a procedure. Now, what are the ways in which you do a PA banding? What is the criteria that is used for deciding how tight should be the PA band?
We use Trussler's rule for doing the PA band.
What is Trussler's rule?
So that would be 20 plus the
weight of the patient.
That would be 20 root plus weight for the patient, or modified Trussler's formula would be 24 plus weight in kg for the patient.
Okay. So this is basically a fixed millimeter where you take a Mercilin tape, you mark. Suppose let's assume that the baby is 3 kilograms, 20 plus 3 is 23. So 23 millimeters is marked. 2 markers are put on the Mercilin tape. You loop it around the pulmonary artery and approximate these 2 marks very close together till that then you feel that is the end point. So this is basically purely a dimension based approach for pulmonary artery banding. What is the other method of doing a pulmonary artery banding? So one method is purely based on dimensions. Second one is based on?
Second would be based on the post PA band saturations. How it would be the saturations, like if there would be a 50% drop in the pressures, that would be considered as an adequate PA band.
Okay.
And sometimes mean pressure of the 50 liters would be considered to be correct.
Okay. The way to answer this will be the first one will be a dimension based PA banding. The second one will be a hemodynamic influenced PA banding, which means you put a distal pulmonary artery needle and keep continuously transducing the distal pulmonary artery pressure. So you keep on tightening till you get a sufficient fall in the pulmonary artery pressures. If you are doing a pulmonary artery banding for a patient just to control the pulmonary blood flow, but the candidate is suitable for a eventual biventricular repair, then you reduce the PA pressures to almost 1/3 of the previous pressures. Whereas if you are having a patient who is ultimately destined to be univentricular, then you drop down the PA till the PA mean becomes almost close to 15 to 20 millimeters of mercury. So this is second way of performing a pulmonary artery banding will be hemodynamically driven pulmonary artery banding. Now, in these two conditions that I mentioned, that is biventricular repair or univentricular repair. In biventricular repair, where you want to an eventual biventricular candidate, you want to do a pulmonary artery band, you allow the PA pressure to be even up to 1/3 of the aortic pressures. Whereas in an ultimate univentricular patient, you tighten it till you get the PA mean pressures to almost 15 to 20 millimeters of mercury. But there are two other conditions where you do the PA band with an
yes,
not
to retrain the LV.
Correct. So in
cases of CCTGA, where we have a tricuspid regurgitation, we have an intention of splinting the interventricular septum, so that along with the control of the tricuspid regurgitation, the patient is prepared further for a double switch operation. And in late presenters for the TGA, we can retrain the LV for further arterial switch operation.
Correct. In those two conditions, you will be doing the hemodynamically guided PA band, not by monitoring the distal PA pressure, but by monitoring the proximal PA pressure, which means it is below either the left ventricular pressure or the proximal main pulmonary artery pressure is being monitored. It's very difficult to put in a needle into the proximal LPA, proximal main pulmonary artery. So it is often measured by what is the LV pressure. So this is the hemodynamically driven. The third one will be anesthetic parameters driven. So what is anesthetic parameters driven? You start doing the pulmonary artery banding. You allow the saturation to drop up to 80%, but don't drop it further. Or number two, look at the end-tidal carbon dioxide. Look at if the end-tidal carbon dioxide is remaining around in and around 40, then you accept. If it goes to 50, 55, that means the patient is truly not getting adequate amount of pulmonary blood flow to wash out the carbon dioxide. So this is anesthetic parameters driven pulmonary artery banding. So this is a third type of pulmonary artery banding. So the parameters that you look at it can be either totally dimension based PA banding or hemodynamic based PA banding, which means you are primarily depending on pressures, or on anesthetic parameters determined PA banding, where you look at PaCO2 and saturations, SpO2s. So these are the three different methods in which you will be doing the pulmonary artery banding. What are the various diseases where you do pulmonary artery banding? You have already told about corrected transposition. You have told about detransposition. In both the conditions where you want to drain the left ventricle, you told about an univentricular and biventricular candidates, biventricular to protect the pulmonary blood flow and univentricular to eventually get them for a bidirectional gland. What are the other reasons where you will do a pulmonary artery banding?
So, supposedly, if a patient of a univentricular repair, he has crossed the, he's still in an increased pulmonary blood flow. Sometimes we do a late PA band, which is a palliative procedure, rather than going for a further next surgical procedure. Sometimes we do a palliative PA band for patients who have crossed the age of PA banding, like who have crossed 12 weeks. So at 10 months, if they present to us with an increased pulmonary blood flow, just for a palliative PA band can be done.
Okay, PA band as a definitive final procedure where you just want to get some amount of control. I'm asking about what are the other reasons where, apart from univentricular hearts, the biventricular, complex biventricular repair, all univentricular hearts, detransposition and L transposition, where there is, you want to retrain the ventricle. Somebody has mentioned that in a corrected transposition.
Sir, in hypoplastic, that will be the part of the Norwood only.
Correct. So a group of conditions where you do bilateral pulmonary artery banding. So what are the conditions where you do bilateral PA banding?
Sir, in hypoplastic left heart procedure, as the first, in the Norwood first stage, before.
Any other condition where you do a bilateral pulmonary artery banding? Very good. Truncus. Truncus arteriosus also is a condition where, if suppose the patient is absolutely unfit for doing a corrective procedure, let's assume that the child is about 1.2 kilograms and the child has got a truncus arteriosus with large pulmonary blood flow. It will be very tough to get a truncus repaired and put in an RV to PA conduit in a tiny baby. So you need definitely time. So until that time, you can palliate. Truncus arteriosus and hypoplastic left heart syndrome are two conditions where you can try a bilateral pulmonary artery banding. So these are all the variety of conditions. In fact, one Dr. Rajaguru was mentioning that in corrected transposition to prevent severe tricuspid regurgitation, you do a septal shift. It can be done as a part of even a tricuspid valve repair, a tricuspid valve replacement in patients with corrected transposition in order to give some amount of septal shift. Some pulmonary artery banding can always be added in every corrected transposition, whoever is going for left AV valve surgery. Is there any other conditions where pulmonary artery banding is experimentally considered? Is there any role in dilated cardiomyopathy for a pulmonary artery band?
Yes, so there is a role, but I'm not very sure. But there is a role of PA band in dilated cardiomyopathy. Okay, fine. And you are so we were so instead of taking it as large VSD with bicuspid aortic valve, we can state that large VSD with some form of anatomical abnormality which precludes the immediate corrective surgery. Then your third diagnosis is VSD, who presented with a residual VSD, and that residual VSD was operated in the second stage. Correct? Yes, sir. And there was there might have been a subaortic membrane, which is causing progressive LVOT obstruction. It might cause LVOT obstruction, or the subaortic membrane, which is progressive, which damages the aortic valve, leading to an aortic regurgitation that might be leading to the current condition of the child at 17 years of age.
Okay. So can you consider any form of cyanotic heart disease with a minimal cyanosis? Say Character transposition, VSD, where...
Yes, sir, for for CCTG, VSD, we can go for a PA band at first stage, and then maybe because there would have been a tricuspid regurgitation, the child is not suitable that time for a double switch operation. So for retraining as well as for controlling the PA large pulmonary blood flow, might have gone for a PA band, then at 3.5 years of age gone for a total repair. But he is still asymptomatic for 13 years. So if physiological closure has not been done, then the patient's RV the systemic ventricle would fail only in the 4th decade of life. But she's only 13 years of age. Or otherwise, at 13 years of age, if a CCTGA who has been completely repaired is presenting to us, it might be due to arrhythmia or a heart block-like condition, but she doesn't have any symptoms of palpitations as such. So,
you were mentioning something about if a right ventricle will fail only on the 4th decade. Can I get it much more clear from you?
Sir, in a normal normal natural history of congenital corrected transposition of great arteries, if the systemic ventricle is the right ventricle, it would start filling in the 4th decade when systemic hypertension or other disease would start to set in, not in the natural history wise.
So talking about corrected transposition without any associated lesions.
Yes.
Where primarily they start off with some amount of tricuspid regurgitation and progressively go into RV dysfunction.
Yes, sir.
But this is a patient who had 2 open heart surgeries, no?
Yes,
so
sir.
There be a corrected
yes,
transposition with a ventricular septal defect, and you do a physiological repair. When do you anticipate the right ventricle to fail?
That would fail earlier, sir. Maybe second decade.
Quite early, no?
Yes, sir. Second decade.
Okay. So very early failures is anticipated. If you are closing the ventricular septal defect, a physiological repair in a corrected transposition.
Yes, Hello.
Yeah, Dr. Rishika, briefly, I lost the connection. Fine. So I would agree with your variety of causes. Now, can you go ahead with your clinical examination?
Yes. Yes. Child is conscious, cooperative, alert, oriented to time, place, and person, sitting comfortably on the chair with a weight of 40 kg and height of 150 centimeter with a BMI of 17.7 kg per meter square, with an upper segment 74 with lower segment 76 and an arm span of 152 centimeter. Vitals wise, she has pulse of 70 per minute, regular, normovolumic, all pulses equally well felt with no radial or no radiofemoral delay. Blood pressure in all the limb is equal with the normal respiratory rate. She is not stenotic. JVP is elevated 8 centimeter above the sternal angle. and B waves are prominent. Abdominojugular reflux is negative, and there are no peripheral signs of aortic runoff. She doesn't have any pallor, ictus, cyanosis, clubbing edema, or lymphadenopathy, or signs of infective endocarditis. There are no chest and bony deformities. Skull, spine, and facial is normal with no facial dysmorphism. Trachea is central with chest bilaterally symmetric with no precordial. Apex is in the left fourth intercostal space 1 centimeter lateral to the mid-clavicular line. Tapping type of apex, LV type with medial retraction. A grade 2 left parasternal heave, systolic, synchronous with the apex beat. A palpable second heart sound. No, there are no epigastric pulsations, no thrill, any other pulsations. There is a midline sternotomy scar present, no sinuses. On percussion, left heart border corresponds to the apex and right heart border is retrosternal. Second left intercostal space is dull on percussion. Liver dullness is on the fifth intercostal space in midline, and stomach tympani is on the left, suggestive of abdominal situs solidus. S1 is loud, S2 loud and single with absent S3 and S4. A grade 3/4 low pitch, rough rumbling, mid diastolic murmur in the apex, best heard with the bell of the stethoscope with patient in the left lateral position, breath held in expiration. A grade 3/6 soft blowing, high pitched pansystolic murmur in the tricuspid area radiating upward, best heard in inspiration. There are no clicks and no opening snap present. Another system examination is normal. There are no open neurological deficits. Tone power reflex is normal, and there is no organomegaly. So I have a 17-year-old female with a known acyanotic congenital heart disease with 2 hospital admissions for pneumonia and failure to thrive with anorectal malformation, middle surgeries 6 months and 3.5 years of age, who remained asymptomatic for 13 years and now presented with dyspnea on exertion, which is suggestive of NYHA class 3 with a regular pulse and blood pressure with an elevated JP with prominent V waves, a tapping type of apex and no cardiomegaly with a loud S1 and a single foot heart sound, the mid-diastolic murmur at the apex and a pansystolic murmur at the tricuspid area. I would like to consider situs solidocardia, asymptomatic heart disease with increased pulmonary blood flow. Post-operative, probably AVCD has severe mitral stenosis with severe tricuspid regurgitation, severe artery hypertension in NYHA class 3 in sinus rhythm without any history of infective endocarditis, who is undernourished. Probably syndrome. Hello?
Yeah. Okay.
Yes,
So repaired AV canal defect with now currently left AV valve severe stenosis.
yes.
What are the other possibilities? In the clinical examination, you are telling abdominojugular reflex negative. What do you mean by that?
Reflex negative, that is currently here. When I pressed the abdomen for almost 10 to 15 seconds and the pressure was released, there was an immediate fall of the JVP, which if the abdominal reflex had been positive, it would have been lasted for more than 3 to 5 beats, but there was a fall of the jugular venous pulse.
Abdominojugular in a patient who is having it was 8 centimeter above the sternal angle of Louis, you told, right?
Yes, sir.
So it is a significantly elevated JVP. In this elevated JVP, when you give an abdominal compression, what do you anticipate in the jugulars?
So there should be a distension and
increase in the jugular venous pressures.
yes, sir.
And what is negative in that? Abdominal jugular reflex negative means what?
So the fall of the JVP normally is after 3 to 5 cardiac cycles if the patient is not in an incipient right heart failure, but because the fall is the distension is it is in 3 to 5 after the 3 to 5 cardiac cycles only. That's where the reflux is negative. Had it been consistent after the 3 to 5 cardiac cycles, that would have been a positive abdominojugular reflux.
It is not during the release that you are checking. It is during the compression that you are checking. Basically, whenever you are compressing the abdomen, few things happen. Number one, the diaphragm is getting splintered. You are increasing the intra-abdominal pressure, which increases the abdominal venous return, the splanchnic venous return back into the right atrium. So this increase in the load of the volume within the right atrium, if the heart is not able to tolerate this additional volume, it tries to increase the jugular venous pressure. In every patient, whenever you try to press on the abdomen, there may be a very transient elevation, but there will not be a sustained increase in the venous return created by a abdominal compression.
Artificial.
However, if the patient is in heart failure, since there is a grossly distended splanchnic venous bed, you will be able to increase the right atrial pressure on a sustained manner so that it lasts for a longer period of time. So in a patient in whom, if you are pressing the abdomen and if you are briefly increasing the jugular venous pressure, that lasts only for a few beats and immediately normalizes. That means this is only caused by a transient increase in the volume of the venous return to the right atrium, but the heart compensates for it within few cardiac cycles. In a heart that is in incipient heart failure and you are not able to the heart is not able to tolerate this additional volume, it will be remaining sustained. But when you take your hand out of the abdomen from the pressure, immediately it will drop back. In everybody, it will drop back. It will not stay for 3 to 5 cycles after the hand compression is taken off. Because the moment you take off, immediately the positive pressure on the abdomen is lost. No longer you are pushing an additional volume of blood into the right atrium. So it is not upon release, it is upon the compression. So abdominojugular reflex means an elevation of the jugular venous pressure caused by an increase in the right atrial venous return, which is secondary to number one, splinting of the diaphragm, and number two, increasing the pooled splanchnic venous blood back into the right atrium, thereby increasing the right atrial filling. And in patients with incipient heart, so you should not tell that it is upon release, it is persisting to stay three beats. Upon release, it will immediately normalize. It has to fall. And in general, people will say that if the patient is already having an elevated jugular venous pressure, there is no need to press the abdomen in order to bring out a further elevation of the right atrial pressure, because this process of increasing the intra-abdominal pressure is going to compress on the congested liver, whose capsule is already stretched. Thereby, you will result in more amount of hepatic capsular stretch and more amount of pain and tenderness. So in a patient who is having a manifest jugular venous pressure elevation, there is no need to press the abdomen and demonstrate the pressure. What are the utilities of abdominojugular reflex in clinical practice?
So abdominojugular reflex is usually when the JVP is either borderline elevated or there is a incipient right ventricle failure, or there is a silent tricuspid regurgitation which is suspected.
Okay. Abdominojugular reflex is useful in two.
It is also, I mean, there is a falsely positive in COPD patients.
Okay, abdominojugular reflex has got two utilities. Number one is in identifying a incipient heart failure. That means there is heart failure, but currently the patient is on significant doses of diuretics that he is not having a JVP elevation. You can bring about a JVP elevation by compression. So an incipient cardiac failure is exposed. Another reason will be, if suppose the patient has had a midline sternotomy, some form of surgery, and you want to decipher out what is the type of surgery in those patients, if you press the abdomen and if you are not able to get the jugulars significantly elevated, that means this is a surgery where the superior vena cava is getting disconnected. Like a Glenn shunt, or
Yes.
a patient who is having a superior vena caval obstruction where the superior vena cava is disconnected from the atria. So this actually tells us whether the SVC is in continuity with the heart or discontinuous with the heart. So for identifying an incipient heart failure, as well as identifying a type of surgery where the superior vena cava is getting disconnected from the heart, an abdominojugular reflex will be useful. Okay?
Yes.
Yeah. Go ahead. So I mean, let us get back to the diagnosis. So you mentioned that it is a patient with left AV valve stenosis as well as left AV valve stenosis with severe pulmonary hypertension, right?
Yes.
Okay. If you're you mentioned that there was a medial retraction, no, in the apex.
Yes, sir.
What does that mean?
Sir, medial retraction, the apex means the apex is during the isovolumetric contraction or the early rapid ejection phase, the LV moves in a counterclockwise direction. So what comes to the apex is the LV, and the pulsations which are because the RV is retracted medially to the interventricular sulcus. So it goes back, I mean, it is retracted in the direction which is the RV is retracted.
So a medial retraction, in other ways, means that the left ventricle is primarily responsible for the apex, right?
Yes, sir.
So do you expect that in a severe AV valve stenosis? Which chamber is underfilled in a severe AV valve stenosis?
So the left ventricle should be underfilled.
Underfilled. So then how will the left ventricular impulse become prominent enough for you to observe a medial retraction? Normally, it is a finding that is seen in left ventricular volume overload. Like, for example, a patient who is having a mitral regurgitation or an aortic regurgitation, you can have a apex which is having a medial retraction. This is a patient with severe left AV valve stenosis and an underfilled left ventricle, no? Correct?
Yes, sir. Yes, it's.
So
I made the wrong. So yes, it's wrong. I mentioned it wrong.
So it may not be the left ventricular impulse may not be forcible to create a medial retraction in a patient who is having an underfilled LV apex. Okay, so what are the differential diagnoses? Let us assume that currently we agree for a clinical diagnosis of left AV valve stenosis associated with pulmonary hypertension and secondary tricuspid regurgitation. I agree all with the clinical findings. What are the other possible diagnoses?
So the findings are very consistent with the left AV valve stenosis. So
okay,
there might be a congenital AV valve regurgitation, which would have been repaired
Okay.
twice, and maybe a cleft mitral valve or something. So after the correction of the cleft, which has led to overcorrected cleft leading to a mitral stenosis.
Okay. So again a repaired AV valve. Yeah, I mean, one is in the setting of AV canal, the second is in the setting of some other congenital mitral valve where it is a repaired mitral valve is again getting into a mitral stenosis and pulmonary hypertension, correct?
Yes, apart from it, then I would have, if in other conditions, if I would consider that there would have been an AV valve regurgitation, or I'll have to count. Means apart from a congenital heart disease might be a superimposed acquired heart disease, but there is no such history of a rheumatic kind of heart disease. However, there is a possibility that 50% times there is no history of a rheumatic heart disease, but there might be a possibility of it.
Okay. Yeah, I agree that in our country probably, yeah, rheumatic heart disease can happen. Only one point that maybe against it will be, she has been seen by various doctors and
doctors constantly. So even if the symptoms would have been missed, the echocardiographic findings might not have been missed.
And so the patient would have been started on some form of penicillin prophylaxis if it had been a rheumatic mitral disease, right?
Yes, sir. Or otherwise, totally.
Congenital mitral stenosis, which was not amenable for a corrective procedure during the initial VSD closure and was left for a conservative approach.
Yes, sir.
Sometimes a mild to moderate congenital mitral stenosis, like for example a double orifice valve or a parachute valve, you may not be able to do an AV valve correction, and the valve may not be large enough for you to replace. So in those conditions, sometimes you will leave behind a mild to moderate MS and just go ahead and close the VSD and do the other work and see what happens to the natural history of the congenital left AV valve stenosis. Right? Let's assume a small baby with a ventricular septal defect with a mild to moderate congenital MS. Then that also can be a possibility. So you mentioned about three different things. One is a repaired AV canal. Second is a repaired dysplastic mitral valve. And the third is possibly an underlying congenital MS. Last may be a rheumatic MS. But since there is no prophylaxis, probably that is quite low in the list. Yeah, fine. Because the findings of low-pitched rough rumbling mid-diastolic murmur at the apex, which is becoming prominent on expiration, clearly points to a left AV valve stenosis. I agree with your differential diagnosis. Okay, now, so how will you clinically differentiate between repaired congenital mitral abnormality which was repaired, which is with severe stenosis, or an AV canal which has been repaired with severe stenosis? What investigation will help you in differentiating these things?
I missed the question, sir.
See, we had you mentioned about four conditions. Number one was a repaired AV canal defect with a severe MS, severe left AV valve stenosis. Second one was a repaired mitral valve, a primary mitral regurgitation which is caused by either a cleft or some other condition with a VSD, and that AV valve which has been repaired is now getting into mitral stenosis. Third is a congenital MS, and fourth is a rheumatic additional overlying MS. Between these four conditions, how will you differentiate the four?
Clinically, sir.
Not clinically, the next stage now.
Sir, I would, yes, sir. An ECG might give some idea that whether it was an AV canal defect or whether it was just a VSD. I would expect a superior axis deviation in a classical AV canal defect as compared to a VSD, and a counterclockwise rotation. It might give some idea about VSD. And after that, I'll go for a echocardiogram.
Okay. So in a patient with the AV canal, it will be completely a left axis deviation. Whereas if it had been a large VSD with a repaired mitral valve, which is going in for a progressive left AV valve stenosis with progressive pulmonary hypertension, the pulmonary hypertension will drag the axis more and more rightward.
Right.
So it's more likely to be right axis deviation if it is a VSD operated with a repaired AV valve. Whereas if it had been in the setting of AV canal defect, it will be a left axis deviation, right? Correct. I agree with you. So now show the ECG.
Yes. So my colleague would share the.
Yeah. In the meantime, when they are sharing, you can tell me why there is a left axis deviation in an AV canal?
Basically, in a AV canal defect, the bundle of his is displaced inferiorly. So his bundle is shorter than the normal and is posteriorly placed. The left bundle branch is displaced posteriorly, and it arises from a common bundle, after which it immediately enters the ventricular septum. And the left anterior division of the bundle has less fibers compared to the normal, and which are increased in length than the left posterior one, which provides the small branches to the posterior wall of the left ventricle. And the right bundle branch is abnormally long, and this gives the classical characters of the ECG.
So which bundle is activated early? You mentioned about left anterior bundle, left posterior bundle, right bundle. Which is activated early?
So the left bundle.
Left which one? Posterior, anterior?
So the left anterior bundle is activated early.
I'm asking you which bundle is activated early?
The left posterior bundle is short. The left posterior bundle is
left posterior bundle is activated early because the AV node is posterior. So the posterior, yes, posteriorly and inferiorly located AV node conducts into the ventricle and activates the left posterior bundle far earlier. Left posterior bundle, when it is activated, it creates a left anterior hemiblock pattern. If it had been a left anterior bundle activation, it would have created the left posterior hemiblock pattern. It would be right axis deviation. Correct. Show me the ECG now. What are the other features, other ECG features of AV canal defect?
So there would be a counterclockwise rotation, and the frontal QRS axis would be manifested by dominant S waves in lead 3 and AVF, and prominent R waves in AVR, and counterclockwise rotation, that is Q waves in lead 1 and AVL. Also, there can be a prolonged PR interval.
Correct. Prolonged PR interval is another reason. What is the reason for prolonged PR interval? Again, the same reason. The very posteriorly located AV node and a longer distance to the His bundle. So again, the AV interval has got two components, AH interval and HV interval. So here the AH interval is prolonged because of, again, distance between the penetrating bundle, the AV node to the penetrating bundle. Yeah, show me the ECG.
So, yes, sir.
So what is the ECG showing?
So this is a 12 lead 4 channel standardized ECG, but with a heart rate of almost 300, around 80 per minute, and there is the P waves appear to be normal only. The P wave axis is normal, situs solitus 1 and AVR 1 is positive, AVF is positive, AVR is negative, so situs solitus, and the QRS axis is 1 is ecophasic, so if it's positive, so it's basically a 90-degree axis only, sir.
Okay.
And there is a 1 in Q waves in 1 and AVL, so counterclockwise looping is there, and apart from it, there is a right bundle branch block which is incomplete. It's less than 120 milliseconds, and there are the biventricle forces only.
You mentioned about counterclockwise loop, and you told that there is Q waves in 1 and AVL, correct?
Yes, sir.
This patient is having both 1 and AVL, which are predominantly negative.
Negative.
What is counterclockwise loop? What is the meaning of the word counterclockwise loop?
So, in counterclockwise depolarization.
Yes. Yeah. Tell me.
We stand at the foot end of the patient in the lying down position, and we see the axis of the heart in the horizontally rotated position.
Is counterclockwise rotation a feature of frontal QRS axis, which means 1, 2, 3, AVR, AVL, AVF. This is the frontal QRS axis. So this is almost the coronal plane of the patient. Okay. So counterclockwise loop means the QRS vector, it's QRS vector. That means the early part of ventricular depolarization, mid part of ventricular depolarization, late part of ventricular depolarization, which represents Q, R, and S. In what way it progresses over the entire duration of the depolarization. The entire depolarization is a brief event that lasts for about 80 to 100 milliseconds. Now that is the duration of the QRS. If it is a counterclockwise loop, that means the initial depolarization is, say, towards plus 120 or plus 130. That is a left bundle to right bundle activation. This results in what is called as the Q wave in 1 and AVL. So that is the initial vector. Then as the depolarization now spreads to the whole of the ventricle, that initial vector that was initially directed towards, say, plus 120 degree, now starts moving towards 90, 70, 60, 50, 40, 30 like that. As the entire ventricle gets depolarized, it continues till it goes to minus 20, minus 30, minus 40. So the initial short vector of Q wave is directed around plus 120 to plus 150. In fact, it will be easier for me to draw and show, but unfortunately in a Zoom we cannot draw a picture and all. See, can you follow me? Like the initial QRS depolarization, the earliest part, or in other words, the first 20 milliseconds or 30 milliseconds is directed from left bundle to right bundle, and this direction is around plus 120 to plus 150. So the Q will be prominent in 1 and AVL. And the progressive continuous activation of the QRS. Let me see whether I can share. Amitabh, can you allow me to share? I will just draw a picture and I can share.
Yeah, sure. Just a minute, please. Pratap, stop sharing. Pratap, please stop sharing. Allow sir to share.
I have stopped sharing, sir.
Okay. Sir.
Now, can you tell me how I can show that the picture that I'm drawing on a paper here? Maybe I will do one thing. I will show you now. It's very bad. Okay. Can you see the picture?
Yes, sir, it is visible.
Okay, now let me see how I can hold my phone as well as this together. Actually, if I had logged in on my computer, then I could have used the widescreen, but I had logged in on my phone. See, just to watch this picture, I will now tell you. Now you continue to watch. Are you able to see the numbers that I had drawn?
Yes, sir.
See, what I had drawn is 20 is the initial activation. Then at 40 milliseconds, 60 milliseconds, 80 milliseconds, 100 milliseconds, slowly the current keeps on becoming more and more. Just imagine the first 20 milliseconds is a current that is coming from the initial activation of the left posterior fascicle, and the current is now traveling across the ventricular septum towards the right side. So that results in an initial vector that is directed from left to right in the direction of around plus 120 to 150. So this will produce an initial Q wave in 1 and AVL. But as the ventricle gets depolarized more and more, that means the left bundle is now conducting more and more towards the Purkinje fibers and activating more and more left ventricle. As time goes on, 40, 60, 80 milliseconds, slowly the vector becomes more and more and more towards the left ventricular apex, which is now in the 0 to 90 degree. Now, since there is a left posterior bundle activation and a left anterior hemi block, the late part will be more and more activated. That means minus 20 and minus 30. Those areas will be the last part to get activated. So the whole vector, when you connect it, I will now draw that and show you.
Shiva, I've got one picture. Will it help you? I've got one picture.
Yeah, you just show me. Now I will show this picture. Now, what I had drawn here is the counterclockwise loop. So this starts from around plus 120 and keeps going far towards the this counterclockwise rotation, what you are writing is not the same counterclockwise rotation of the what is described for AV canal repair. It is in frontal QRS vector. 1 and AVL being negative and 2, 3 AVF being positive. The initial Q waves getting activated, 1 and AVL being negative and 2, 3 AVF being positive is counterclockwise rotation, and this is in a frontal QRS, a picture seen in AV canal. This clockwise rotation and counterclockwise rotation that you are seeing is on the horizontal plane. This is to differentiate between whether the right ventricle is dominant or left ventricle is dominant, not this counter. We are talking about counterclockwise QRS axis in reference to the pattern of activation. Now, are you continuing to see my picture?
Yes.
Okay.
Yes,
now,
yes.
Just a short, give me a moment and I will now draw a clockwise loop. I'll just show you, just a second. I wish I had logged in on my laptop. If suppose, are you able to see my picture now? I'm not able to see my own picture. Can you see a picture?
If you can just hold the camera, just move your hand towards the left.
Actually, I was seeing the my own picture, but now I am seeing your photo.
No, I'll just a moment.
Yeah, super.
Yeah.
Now I am able to see my camera. Once again, I will get it now. So now you see that this is in another plane. This is what is called as clockwise rotation. So in a clockwise rotation, what happens is the right ventricle is the dominant ventricle. So progressively the vector keeps going more and more and more and more towards the right side. So what happens? There will be an initial Q wave in 2, 3 AVF, but subsequently a very tall R wave. So the activation is in the other direction. Now I have already marked the arrow. So this is what is called clockwise activation. Now I will again now show you the counterclockwise activation. That counterclockwise activation is like what starts at 120 and goes to -20 is counterclockwise rotation. And now you see what starts at around somewhere around 0 and progressively comes rightward and finally gets into a right axis is the clockwise loop. So a typical of clockwise loop is tetralogy of Fallot, double outlet right ventricle. A typical of counterclockwise loop is AV canal defect. It is in the frontal QRS position. The activation initially is towards +120 to +150, which is opposite to 1 and AVL, and so it produces negative vector in 1 and AVL. But subsequently, the axis shifts and goes counterclockwise. So let me see whether my camera, okay. Yeah, so it starts here and then moves counterclockwise. Whereas in tetralogy, it starts here. So 2, 3 AVF is negative and then it moves clockwise. So final vector will be more and more directed towards the 120, 150. So that is what is called counterclockwise loop. Yeah. So in this patient, absolutely there is no, it's more of a rightward axis. Your QRS axis is a little more than +90 and there is prominent RV forces which can be explained by just the pulmonary hypertension, but it is a rightward axis. So it rules out a repaired AV canal. But still, a congenital MS. Show me again that ECG. A congenital mitral stenosis, a repaired dysplastic mitral valve, all can be possible because they can be having a rightward axis. Correct. Now let us analyze this. You said the PR interval is normal. Normally, if there is a severe mitral stenosis, you would have anticipated a left atrial enlargement. Here, the atrial forces are not very significant at all, right?
Yes.
So completely, the left atrial forces are insignificant. There is a small P-terminal force in V1, but that is not suggestive of a left atrial enlargement.
The Morris index is not more than 0.04.
Correct. So in a patient with a severe mitral stenosis, one of the characteristic hallmark is left atrial enlargement, and that is missing. So does that give any sort of clue about left AV valve stenosis, but without a left atrial enlargement? So what can be a possibility? Actually, one condition where severe left AV valve stenosis is not associated with a left atrial enlargement is conditions like, for example, where there is a large ASD and the ASD is decompressing the left atrium. Like, for example, a Lutem-Bascher syndrome will not have a left atrial enlargement. Here, there is a definite evidence of a left AV valve stenosis because you had an apical mid-diastolic murmur, but that is unassociated with an atrial enlargement. So that is of some point that is going against a severe left AV valve stenosis. The only thing that we have ruled out is possibly an AV canal defect. And the absence of left atrial enlargement needs to be identified now. Okay, show the chest X-ray. First you showed the chest X-ray and then there's the ECG came. So maybe you can go one back and show the chest X-ray. Okay. So what are the findings in this X-ray?
So this is situs. This is an X-ray chest, plain PA view with an upper abdomen with stomach bubble towards the left side of suggestive of a situs solitus. The cardiac shadow, there is no cardiomegaly. The CT ratio is less than 0.5. However, there is a straightening of a left heart border which can be seen, and there are features of pulmonary venous congestion only in the upper lobe is present, capitalization. Apart from it, there are no features of pulmonary artery hypertension. The pulmonary artery does not seems to be dilated, or the right pulmonary descending artery is also not dilated. And the apex seems to be upturned, maybe an RV kind of apex. And I would have expected a double contour, but a double contour is also not seen. But there is definitely a carinal angle is, I think it is more than 90 degrees.
Okay, so there are, for your congenital mitral stenosis, we want two chambers to be shown very prominently. Number one is the left atrium and number two is the pulmonary veins. So pulmonary veins, pulmonary venous hypertension will be shown as equalization or cephalization in the early stages, but subsequently it will be shown as perihilar haze with pulmonary edema. Now, in this particular X-ray, I am not seeing any evidence of pulmonary venous significant hypertension at all. There is the upper pulmonary veins are not looking very prominent.
Yes.
There is not an equalization or cephalization. Similarly, there is no perihilar haze. So the pulmonary venous hypertension itself, I am not convinced. Number 2 is left atrial enlargement. A left atrial enlargement should show up as, if it is enlarging on the rightward side, it will show a shadow through shadow. If it is enlarging superiorly, it will widen the carinal angle. If it is enlarging towards the region of left atrial appendage, it will produce flattening of the left heart border. Here, maybe there is flattening of the left heart border, the left atrial appendage and the main pulmonary artery segment. It's not concave. It is almost sort of little flat. So maybe left atrial appendage may be enlarged, but definitely the carinal angle seems to be normal. The left bronchus is having a left bronchus will be completely horizontal in a patient with left atrial enlargement. Normally itself, the right bronchus is at an angle, whereas left bronchus is more horizontal. And more the left atrial enlargement, the left atrial appendage will become left bronchus will become completely horizontal. Here you are not getting that horizontality. So neither there is a left bronchus becoming horizontal, or there is a shadow through shadow. Maybe there is some left atrial enlargement because that area is not concave. And you told there is no cardiomegaly, but I would say it is probably around 55% CTR. If you objectively measure with a caliper, it looks like some amount of cardiomegaly. But we are not getting a definite feature of pulmonary venous hypertension. Sometimes what happens is, what are the conditions in which a pulmonary venous hypertension can be completely masked despite significant mitral stenosis? If there is a severe precapillary hypertension, there is a protective severe precapillary hypertension, which is called as second mitral stenosis. And if that is very profound, it can sometimes mask the pulmonary venous hypertension, which means it will mask even the findings of mitral stenosis. It will mask the mid-diastolic murmur. It will make the mitral stenosis becoming silent. But here you heard a very loud murmur. So that means there is a sufficient amount of blood that is flowing through the mitral valve. We would have anticipated more pulmonary venous hypertension. Here again, pulmonary venous hypertension is not looking very classical. So the ECG findings that were little odd was the absence of left atrial enlargement, and the X-ray findings that are a bit odd are even though there is left atrial appendage enlargement, the left bronchus is not lifted, and through the right heart we are not able to see the left heart border, left atrial border. There is a widening of the superior mediastinum, right?
Yes, sir.
What is the reason for that? We are able to find a left arch with a left descending aorta, but there is a widening of the superior mediastinum, slight prominence of the superior mediastinum.
The SVC is...
It's coming at a higher level. Widening of the slightly prominent wide superior mediastinum. Okay, so let us move on to, so there are certain odd findings like absence of significant pulmonary venous hypertension. Yeah, go ahead and show the X-ray and describe the X-ray.
This is an apical four-chamber view with the color compare. It shows the all four chambers. So the LA definitely appears to be enlarged in this
Correct.
view.
Yeah.
Also the right atrium also appears to be enlarged only, sir.
Okay.
And in the valve appears to be thickened.
Okay.
And in the there is a presence of a membrane kind of thing, or it's not very clear. But I think there is something above the.
Can it be and repair the AV canal defect? Keep running. How will you diagnose a repaired AV canal defect in a 4-chamber view?
So the displacement of the tricuspid and the mitral valve,
Offsetting of the
tricuspid and the mitral valve.
what
think-
it will be absent. And second, the left AV valve will have attachments of some of the caudal tissues to the interventricular septum itself.
Septum,
Yeah,
which might cause some amount of LVOT obstruction.
Yeah, maybe, but no, to identify that it may be an AV canal will be by the septal attachment of the left AV valve and an AV valve offset, both of which seem to be normal. The offset is normal, and the left AV valve's anterior leaflet is not having any attachment to the interventricular septum. So definitely it is not an AV canal defect. The anterior mitral leaflet is sort of elongated. The posterior mitral leaflet is small, rudimentary.
Restricted motion is there, and the color compare shows a slit-like kind of opening.
More of a eccentric mitral valve jet that is directed more towards the LV lateral free wall. And there is a mild mitral turbulence only. It is not appearing to be a severe mitral stenosis. No, let's see the next, then gradients, and then we'll see. That picture is half of it is missing. I am not seeing.
So there is a tricuspid regurgitation which is in the downward color compare of.
Okay.
So tricuspid regurgitation is seen, which is almost touching the roof. It appears to be a severe tricuspid regurgitation only.
Yeah, severe tricuspid. In this view, we are able to see the mitral flow turbulence also quite well. Yeah, okay. So there is. Okay.
There is some amount of mitral regurgitation also, with very mild mitral regurgitation, but stenosis appears to be significant.
Okay. Okay. What is the finding here?
The apical 5-chamber view, sir, the LVOT seems to be non-obstructed.
Okay.
It's also okay.
The aortic root seems to be much larger, no? Compared to the aortic valve annulus, the aortic root and the aortic sinuses seem to be very prominent. And it looks like there might have been a VSD patch, because that LVOT, the septum that is closer to the LVOT seems to be maybe having some patch, because there is some step or irregularity in that region immediately below the aortic valve. Correct? Is there any appearance of a VSD patch in that area? Just below the aortic valve. The interventricular septum, if you trace from the apex towards the aortic valve, the basal part seems to be slightly irregular, especially in the non-color picture on the left side. That area seems to be a little irregular.
There might be a patch.
No, might be a patch. Okay. So what is the finding?
This is the tricuspid regurgitation color Doppler across it. The pressure is almost touching 4, so almost more than a 64 millimeter of mercury gradient.
Okay.
Tricuspid regurgitation, suggestive of a severe pulmonary artery hypertension.
Okay. It's even more than 4. Yeah. Severe pulmonary artery hypertension.
This is a parasternal long axis view. Just showing the mitral valves. There is a supramitral membrane which is present above the.
Yes. Yeah, a supramitral membrane, correct?
And valve also appears to be dysplastic. It's not a parachute membrane. Only a supramitral membrane is seen.
Okay.
And in the color compare in the parasternal long axis view, there is a significant stenosis which can be observed.
Okay.
Which is the gradient is starting from the membrane only.
Okay.
And the function seems to be normal, and there is no aortic regurgitation which is seen.
Okay.
LA seems to be dilated.
Yeah, LA is dilated. There is a supramitral membrane. Okay.
There is some amount of. This is the color flow across the pulmonary valve. There is a pulmonary regurgitation which is present, and the diastolic PA pressures are around 260.
Okay. Diastolic pressures are
not very
no, on the fourth beat, it is quite high. You see that?
Yes, it is around 3.5 or something. It's around 3.5. So
3.9.
3 into 3, 4, 9. So almost 36. 40 or PA pressures of diastolic PA pressure of around 40. So significant pulmonary arterial hypertension is there.
Okay, so pulmonary hypertension is there. Congenital supramitral. What are the two different types of left atrial level obstruction for the left atrial inflow? One is supramitral ring, and second is
supramitral membrane or cord tritum.
What is
can
it?
Be there.
How do you differentiate between the two?
So the LA appendage is distal in a cord tritum. The LA appendage is proximal in the supramitral membrane, and the PFO is in the supramitral membrane. The PFO is up above the membrane, but in a cord tritum, the PFO is below the.
In a cord tritum, the ASD can be either above or below, but in supramitral membrane, it is always above. Supramitral, yes. Correct. The left atrial appendage is always above, correct. So here, what is the possible diagnosis? What was the first surgery and what was the second surgery?
The first surgery might have been a VSD closure, sir.
Okay.
When the child would have been very small. Second surgery at 3.5 years, they might have tried to remove the supramitral membrane, but as supramitral membrane or the subaortic membranes, they are known to recur. So there is a possibility that the supramitral membrane has recurred now, which is causing the symptoms of pulmonary venous hypertension in this particular child, leading to a pulmonary venous hypertension and pulmonary artery hypertension and signs of the current situation of the child.
Okay. It could have been possible that since the second surgery was a very, very short period of hospital stay with only 5-day exit, I may even think that it is some other mundane, simple procedure like removal of a protruding sternal wire or something that is absolutely not a major cardiac surgery at all. Because such a fast recovery within 5 days in a redo sternotomy and rapid exit, I will not probably anticipate. It would have been some very, very simple, non-open heart, very minor procedure that would have been done because of such a rapid exit from the hospital. Yeah, quicker recovery. So now if you look back the ECG, why, despite the fact that there was a left atrial enlargement, the ECG was not showing a left atrial enlargement. And I do agree that what was the mitral stenosis gradient that we have not shown? You showed the PAH and you showed the.
So that slide is missing.
But somebody who is showing this can tell what was the mitral stenosis peak and mean gradient, because that has to for a RV systolic pressure that is more than say 70 or 80, you need a significant
severe mitral stenosis.
So what was the mitral stenosis gradient would be something interesting to capture, or the Doppler pattern to see.
It was 14 by 9, sir. Mean gradient of 9.
14 by 9. Okay. There was a question about left atrial enlargement will not be there in supramitral ring. Supramitral ring also should have any form of congenital mitral stenosis should have a left atrial enlargement. Exception is carotid atrium. Carotid atrium sometimes may not have a left atrial enlargement, but if there is any congenital mitral stenosis, there should be a left atrial enlargement. So 14 by 9 is not a extremely severe gradients, but
moderate
moderate stenosis, but still there is very, very severe pulmonary hypertension. So now how will you manage this patient?
See, that would be the resection of the supramitral membrane only, sir. Valve appears to be normal only currently, and the child is 17 years of age yet. So she's a female.
In the absence of a very severe mitral stenosis that is documented, that means the gradient is sort of a relatively low gradient. 14 by 9, mean of 9 millimeters of mercury is a very just a moderate stenosis. So in the presence of a moderate stenosis, will you attribute the severe pulmonary hypertension to be exclusively be only due to mitral stenosis? The PAH is now disproportionate, out of proportion to the severity of the mitral stenosis.
So, maybe during VSD closure itself, the might have been the PA pressure itself would have been high only at that time only. But the child was comparatively stable at between 3.5 years and 13 years of age.
Okay.
So because she has currently in NYHA class 2, so I think I can attribute it to mitral stenosis.
Okay. Now, whenever you are having a very disproportionate pulmonary arterial hypertension for a mild to moderate mitral stenosis, one of the fears about doing the corrective procedure will be the patient's pulmonary hypertension may be completely independent of the mitral stenosis. So it may not truly be a post-capillary hypertension. There may be a substantial amount of primary pulmonary vascular disease, or in other words, pre-capillary pulmonary hypertension. So you can anticipate some of these patients to have continued severe pulmonary arterial hypertension even after relief of the mitral stenosis, because MS is disproportionately milder for the severity of PAH by gradients. But by clinical examination, you have told that there is a grade 3 rough rumbling mid-diastolic membrane. Well, probably I will give more weightage to the clinical examination, and hence would anticipate that the patient will likely to recover if you go ahead and operate the mitral stenosis.
Also, sir, she is symptomatic only. I mean, she's an NYHA class 3, decreased exercise tolerance, exertional dyspnea is present. So.
Okay, so what are the reasons why there can be, what is concerning me is the absence of a substantial gradient. So how can you provoke this patient to have a higher gradient and see whether the gradient is high? What are the ways in which you can provoke this gradient?
We can we can provoke exercise in this patient. Exercise would increase the cardiac output, which would cause.
And do an echocardiography immediate post exercise and find out whether the gradient increases.
Yes, sir.
And during that time, also proportionately see if there is a further elevation of the pulmonary arterial pressures. So right now, to get the patient directly onto that theater for a 9 millimeter gradient will be a little tougher. But if by some provocation, if the gradient increases, then I'll be more convinced that MS is fairly significant. Okay. So the few of the odd things that we identified was the explanation for the second surgery was probably not very clearly known, which is very rapid recovery surgery. Clinical examination, whatever points that you showed were clearly pointing out to left AV valve stenosis, pulmonary hypertension, congestive heart failure, TR, and right heart pressure elevation. That is acceptable. And your ECG ruled out an AV canal, but it retained the possibilities of any form of congenital mitral stenosis. The ECG surprisingly was not showing left atrial enlargement. The chest X-ray somehow did not show a severe pulmonary venous hypertension, which probably is corresponding to the low mitral mean gradient that we are getting. Only mean of 9 millimeters means it's not such a significant pulmonary hypertension. So that will probably explain why you are not having severe pulmonary venous hypertension on the chest X-ray. There is an out of proportion pulmonary arterial hypertension. So something that we will try to do will be maybe exercise the patient and see whether there is an increase in the mitral gradient. And if suppose exercise is also not increasing the gradient and it is remaining only 9 or 10, it's not very significantly elevated. We would even do a cardiac catheterization, assess the pulmonary artery pressure. If the MS is mild, the pulmonary artery wedge pressure will be not very significantly elevated. So that way we will be able to assess what is the diastolic pulmonary gradient. That is, what is diastolic pulmonary gradient?
That would correspond to the pulmonary capillary wedge pressure.
Pulmonary artery diastolic pressure minus pulmonary artery wedge pressure. So if the diastolic pulmonary gradient is very, very wide, that means there is a lot of precapillary element. There is a lot of pulmonary vascular disease. So if I get an exercise-induced significant increase of the mitral gradients, I'll be happy to send this patient for surgery. But if I'm getting no exercise-induced increase and the mitral gradients are only very minimal, in and around this 9 to 10 millimeters of mercury, I'll be a little skeptic about sending this patient for surgery because it may be a significant pulmonary arterial hypertension and pulmonary vascular disease. So these were some of the odd findings that we were getting in the overall clinical evaluation. Your presentation was good and your approach was also good. Amitabh, what are your thoughts and the explanations for why that second surgery was too fast track, like a fast track recovery? The explanations for why the ECG is not showing a left atrial enlargement, explanations for why there is not much of pulmonary venous hypertension on the chest X-ray, and why the MS Doppler is only showing mean gradient of 9, which relatively less for a severe PAH. What are your thought processes?
Yeah, Shiva?
Yep.
Yep.
Hello?
Hello?
Yeah. I'm hearing you.
Yeah, I measured the BP 10 minutes before.
Go ahead, Amitabh.
Yes, Shiva, you were asking me something?
Yeah, Amitabh, I was just asking you certain odd things that were there in the total story. You may be knowing the total patient.
Right.
So there was a second surgery which was fast tracked, which means that within 5 days the patient was discharged. So is it something like a very trivial procedure like sternal wire removal or something rather than a true open heart surgery? And second is the chest X-ray did not show a very severe pulmonary venous hypertension, and the echo also is not showing severe mitral gradient. The mitral gradients are relatively less. So is it a disproportionately severe pulmonary hypertension with a lot of precapillary elements rather than it being a postcapillary? So these are some of the questions that we have.
Yeah, I think the second surgery one, and the second one, most probably that was in all, as far as I remember, it was fast track because it was some wire removal or some pacemaker related issues. That's all.
Okay.
So, and the second thing is the chest X-ray. it doesn't show, really speaking, doesn't show that the too much of a venous congestion or venous hypertension. One of the facts we cannot ignore is that the child is relatively asymptomatic as per the parents. Maybe the parents are denying the fact that the child is really sick, but truly speaking, the child can still carry on a good amount of exercise without becoming short of breath. One of the explanations is that the supramental membrane which the child has regrown over time, but at the same time, leaving her with a good amount of exercise capacity because the gradient across the mitral valve is still tolerable. And the child with somewhat by some natural things and all, the child has been able to tolerate it. I think the reason that the LA has been gradually increased in size, which has actually left the patient with some of the LA pressure has not yet been translated to the pulmonary veins to produce enough of the symptoms. That would probably be one of the explanations from my side.
Yeah, I do understand that the mitral stenosis probably is not very, very tight. But what is the reason for disproportionately severe PAH? Was it like the preoperatively before the VSD closure itself, the patient was having some degree of pulmonary arterial hypertension? And
yes, she was. Yes, she was. Some degree of, though the first operation was carried on quite early. First operation was carried on quite early, but the possibility is that some amount of residual pulmonary arterial hypertension must have remained from there. So that is the reason, though the child is not that symptomatic, but the TR gradient is quite high, whether the pulmonary venous hypertension component, as we would have expected from the supramental membrane, is not there.
So it's a moderate mitral stenosis with disproportionately severe pulmonary hypertension, possibly some pulmonary
vasculopathy, because the mitral stenosis alone cannot explain this amount of pulmonary arterial hypertension which the child really has, both clinically and evidence from the echocardiogram.
Yeah, I agree. So some of the findings are odd, but it was a good presentation. Anything else that you wanted to add? Anybody else wants to add?
One of the important points was, Shiva, that one question came up, that the auscultatory findings from rheumatic mitral stenosis, the opening snap and other findings, whether that would be present in a modified mitral valve or, for example, a supramitral membrane kind of thing, or whenever the mitral stenosis, the mitral valve has been operated on, but still has some residual mitral stenosis or some mitral stenosis has regrown, whether the opening snap would be that authentically be heard as in a native valve. This was one of the questions which was really difficult to answer at some stage.
Actually, opening snap is a classical hallmark of rheumatic mitral stenosis with a commissural fusion. When basically, let us now talk about a bicuspid aortic valve with an aortic valvar ejection click, or a pulmonary valvar stenosis with commissural fusion with a pulmonary valvar ejection click. It's basically the doming of that sudden
distillation and
sudden doming of the valve, so that the valve goes into its maximum open excursion in a rapid period of time. The same phenomenon happens in an opening snap in the rheumatic mitral stenosis, which is primarily associated with commissural fusion. So in that, there is a classical opening snap. However, if there is a mitral stenosis for some other reason, for example, a severe subvalvular pathology, or a severe mitral annular calcification, or a congenital hypoplastic mitral valve, in all these conditions, there will not be an opening. Opening snap is a classical hallmark of commissural fusion with a doming mitral valve. So all the other conditions may not give off a true opening snap. It's quite very easy to understand. A supramitral ring is never going to cause an opening snap. Opening snap is a feature of a doming of the mitral valve created by commissural fusion.
The sudden jerky movement of the mitral valve when it juts into the left ventricle.
Correct. It is a feature of commissural fusion.
Exactly.
In fact, it's a feature that clearly states that the patient is operable. The patient is amenable for a valvotomy. It's a good opening snap is an indicator of amenability for valvotomy.
There are some questions in the chat.
So I also wanted to ask that what would be the pre-systolic accentuation or pre-systolic murmur in these kind of patients?
Pre-systolic accentuation can be present in all these conditions, because pre-systolic accentuation is just a manifestation of an atrial systole augmenting the gradients. So pre-systolic accentuation can be present, but opening snap is a feature of commissural fusion and the doming, sudden doming of the mitral valve. So the opening snap should be very classical for rheumatic mitral stenosis.
And so loudness of the S1, like one reason is the valve is in the rheumatic valve, it is due to the stiff leaflets which resonate with the sound amplitude. Another is the elevated LA pressure in the late diastole. So what attributes more to the loud S1?
The loudness of the first start sound is caused by a widely separated mitral valve leaflets till the end of diastole because of the high atrial pressure. And the moment isovolumic contraction phase starts, the rapid movement of the widely separated anterior and posterior mitral leaflets towards each other in a quick manner. The mitral valve leaflets are held far apart by the mitral stenosis, and they force into closed position at the beginning of isovolumic contraction. So the rapidity by which they close is too fast that it produces a loud first start sound. Again, loud first start sound is a classical hallmark of rheumatic mitral stenosis with a pliable mitral valve leaflets. If the leaflets are pliable, they separate out far apart from each other during the end of diastole, till the end of diastole, and beginning of isovolumic contraction. They move all the way from this widely separated condition to closed condition. This rapid movement is responsible. So I would say it's again the loud first start sound, opening snap are all too classical of a mitral stenosis with commissural fusion. And all the congenital mitral stenosis are either double orifice mitral valve or a parachute mitral valve. None of these conditions will have those features very striking. So
one important question by Simran is what I meant is LA enlargement will not be there in supramitral. No, I didn't mean that one. LA enlargement will definitely be there. What I meant was, since there was an insidious onset because the child had an operation where the supramitral membrane was actually taken off. But as you know, the supramitral membrane grows again. And most probably this time, the second time or the third time rather, the supramitral membrane has gradually grown, by virtue of which the LA has got enough of a time to grow up. That is really most probably, since we cannot explain that the disparity between the pulmonary venous hypertension and the pulmonary arterial hypertension, what Dr. Shivakumar was discussing, that probably that the LA enlargement was slow enough to give enough of a room space to so that the pulmonary venous hypertension was not that much. But the pulmonary arterial hypertension might have been a residual pulmonary arterial hypertension from the original VSD or left-right shunt which was there. That means the child, by the time child was operated, might have been there some residual pulmonary arterial hypertension. I agree to your second and third point, but it didn't tell that the LA enlargement won't be there. It is there, definitely, it has to be there. And Pratima, in the work she has again asked, in case of present PVOD, can we give sildenafil in this patient since distal obstruction is present?
Yes. So, yeah, there is this one you can differentiate only when you do a cardiac catheterization. If during cardiac catheterization, if you find the pulmonary artery pressure is too high elevated and the diastolic pulmonary gradient is very, very, very significantly wide, let us assume you are getting 70/40 as the PA pressures, but 15 millimeters of mercury is the LA pressure. That means too much of difference between the left atrial pressure or pulmonary artery wedge pressure and the pulmonary artery diastolic pressure. Then in that case, there may be a role for giving pulmonary vasodilator. So if you are having a disproportionate pulmonary hypertension with no significant mitral stenosis, there is a definite role for cardiac catheterization to assess the quantum of pulmonary arterial precapillary disease versus postcapillary disease. But one another simple finding will be, you just exercise this patient and find out whether a relatively low gradient of say 9 millimeters of mercury during exercise gets provoked to about 20 millimeters of mercury or 25 millimeters of mercury, then that is a good sign that there is a severe mitral stenosis and you can go ahead and operate. But if the mean gradient of 9 millimeters just increases to maybe 10 millimeters of mercury or 11 millimeters of mercury at the end of peak exercise, then that again indicates that the pulmonary hypertension is disproportionate to the mitral stenosis. So exercise hemodynamics in echocardiography as well as cardiac catheterization can be needed to differentiate whether the pulmonary vascular disease is significant.
Yeah, Pratibha has asked the question which we were discussing, like whatever S1 in congenital MS versus rheumatic. I think we just discussing that. Okay. Any other questions from anyone? We picked up this case because it was quite a lot of controversies, Shiva.
Yeah, I understand. Actually, the
findings were not tallying with each other, which will be found.
Some of the findings, yeah, correct. I do agree. The MS is not looking so profound, but by examination, she got a very loud murmur. So I wonder how the gradient is not so high on the echo.
Yeah, yes, that really was a apparent paradox. Really.
One more thing, when you are delineating the gradients, you also have to mention at what heart rate that gradients was there, because the heart rate and the diastolic filling period determine the gradients. If we say that it is 14/9 at a heart rate of 50 per minute, when the patient is either asleep or the patient has been given some small dose of beta blocker, or for some reason, if the patient is sort of bradycardic, it may still be a significant mitral stenosis. Whereas if it is 14/9 at a heart rate of 110, then that means it is really insignificant mitral stenosis. So all mitral gradients have to be quantified with heart rate. That is another one more point that you have to possibly add in your description of the findings.
Right. Thank you, Shiva. Thank you very much for the wonderful class. And the next time, I think one PG from MMM will be presenting.
Yeah, I think I think one person is getting ready for tomorrow. In case if you have time, tomorrow they will present to you.
Tomorrow, I'll fix up the class at the same time, 8 o'clock.
Perfect.
Okay, sure. I'll fix it up.
Thank you.
Thank you very much. Thank you very much, everyone.
Thank you, sir.
Recording stopped.